There is clearly a benefit of the micro pacemakers in terms of the overall major complication rates compared to the conventional transvenous pacing. There's a 63% reduction in major complication rates. There's also a 38% reduction in reintervention and 31% reduction in chronic complications as well. In terms of the pacing system, how does it look? Obviously, you've got a VR and AV. Both of them are same size. Only the allogram is inside is different. It is MRI compatible. So most of the pacing indications, it can be considered as a primary therapy. The way this accelerometer works is, it picks up the atrial contraction signal. I'll just let it run. So you have got the triaxial sort of sensor, which is already used in the VR, but the same sort of sensing is used by the AV, and it picks up the atrial signal contraction. There are 4 waves it comes. So you see the A1 is the start of the ventricular systole, and the accelerometer can pick up that where the mitral and tricuspid valves are closed. A2 is the end of the ventricular systole where the aortic and pulmonary valves are closed. A3 is the passive phase of the diastole, and A4 is the active phase, the atrial contraction phase. So it picks up all 4 and it creates waveforms, and once it's rectified, you get nice waveforms which can be used as a AV sequential pacing, so based on the mechanical contraction. So there is a V marker which sort of delineates the ventricular activity, and there is an AM marker which kind of delineates the atrial activity. So there's 100 milliseconds pass from the electrical P wave to the mechanical contraction. So that is what it uses in terms of AV sequential pacing. So you can program it on a later stage as well based on the echo parameters to get the best out of the system. So it does help in terms of bradypacing. It does smoothens out, and there is about 11 algorithms included in this, which includes the activity mode switch, as well as whether the patient is resting, whether the patient is moving around, and as well as whether there is patient has got AV conduction or not. So it can sense everything. Accordingly, it can cause AV sequential pacing or a BVI or a VVIR. So the results from the Marvel 2 basically is the patients who already had the VR. This new algorithm was inserted in that, and when we looked at it, there was a 94% median AV synchrony, and also there was a jump from when it was VR to sort of AV, there was a jump from 26 to 89% mean AV synchrony. The procedure, it comes with a sheath, introducer sheath, which is about outer is 23 French, and it also comes with the delivery system. There are 3 controls in that. The top one, the blue one, it's so there's the blue control which is to flex when you are in the right atrium. So this one is to flex, and then you can, this is deployment control, 50% deployment just to deploy the tines and then lock it completely. That's the tether release in the end. It's a very, very simple single sort of deployment system. And once you are inside the heart, the previous concern was perforation, but with this controlled deployment system, the perforation rate is very, very low. So you have got that 50% deployment, the tines hold to the trabeculation. After that, you lock it once you release the tension in the catheter. So the perforation rates are literally 0. So how we do it? Obviously, you insert the sheath first in the right atrium, you disengage it, you flex it, go through the tricuspid valve, you create a nice contact with the septum, and you take a picture. Make sure that you are in the septum. And once that is confirmed, once the contact is there, you deploy it half, and then release the tension in the catheter, and then lock it. So there are 4 times, if 2 of them holds, that's more than enough. It gives 15 times the holding force necessary. If you get 3, that's better. If you get all 4 times holding, that's the best. But anything around 2 is fine. So you can do the tethering test once the pacemaker is in place. So the implantation, it's about 15 minutes, skin to sort of skin, almost 20 minutes you can complete the procedure. We did one last week, it's exactly 20 minutes. And even in sort of beginners, it can be done within sort of half an hour's time. So you have a large sheath which you are inserting in the groin. The sheath is there, and the pacemaker introduced system goes through that. And with the flex in that, which I just showed, you flex it, You enter the tricuspid valve, and then you relieve the flex. The catheter is 3D shaped. It's like the septal wire. We already kind of shape it when we do the septal pacing. 3D shaped, so it will go towards the septum. Unless you manipulate it, it will automatically go towards the septum. Once you have the contact, you release the tines, and then you release the pacing fully. And then you check your parameters. If you're satisfied with that, you release the system completely. Once the system is completely released, that is by just cutting that thread in the end, and you can feel the heart contractions and slowly release it. And your pacemaker will be there, and you can close the groin as usual with one pro glide. That's more than enough. So this does work. It has got very low sort of adverse event rates, and the success rate is more than 99%. What if the system fails after 12, 13 years? Either you can put one more, or you can go and retrieve it through the same introduced sheath, use an agility, use a single snare, you go and retrieve it. And even though it says up to sort of 1 to 3 months, the longest is around 4.3 years afterwards has been retrieved. So you can retrieve it and put a new system. So evidence, there are multiple studies that is done. The most recent in terms of the AV synchrony is the Marvel study. And as I already showed in the slide, you do get more than 70% of the patients getting AV synchrony and 94% VDD pacing. And it does improve the stroke volume of the LV as well. The LV OTI shows that. So the pacing, in terms of the mode switch during the patient's activity and the atomicity, it also works well. So there is no passes absorbed because of the motion artifacts. And the thresholds remain good, and all the other parameters remains good. So this is that elderly man I just showed. He had a temporary wire. Sheath is going in. The device, it literally takes 15 minutes. And it's the straddling, that means you are aligning the markers, and it's deployed. And it's closed. And you send the patient home next day morning. So it's as simple as that. And it is also useful in transcatheter valve cases. We have done a double valve replacement, and this one where the patient's risk of infection is there. In conclusion, both VR as well as AV transcatheter pacing system is suitable alternative for patients with brady pacing with a lower overall procedural and device-related events. It is safe with a high procedural success rate. It's provided an alternative for patients with no options, as well as an effective solution for unmet needs, where the patients having recurrent infections, you keep on changing boxes. The micro-AV with the new sort of algorithm with around 11 algorithms in that provides a fantastic AV synchrony and improves LV stroke volume.